Professor Said Nasiruddin sir and Dr. Dipal Adhikari. And I'd like to invite Professor Abdul Wadur sir as well to the dais. And there are two distinguished speakers for this session. I'd like to invite the speaker for the first session, Dr. A.K.M. Monwarul Islam sir, to take his place in the dais as well. So the first topic and the speaker is Dr. A.K.M. Monwarul Islam, who is also my direct teacher. And his topic for today is Epidemiology of Cardiovascular Disease in Bangladesh and Challenges in Primary Prevention.
Respected Chairperson, dear moderator, and the audience, Assalamu alaikum and very good afternoon. Today, I am delighted that I have been invited to deliver this topic, I think which is a very time-worthy topic on this day of World Heart Day. Today I am going to talk to you regarding the epidemiology of cardiovascular disease in Bangladesh, and to some extent I like to highlight on challenges in primary prevention. We know that Bangladesh is a lower middle income country. Its per capita income is now almost $2,824 US, and the life expectancy is constantly increasing, and now this is at 73 years. Healthcare budget is unfortunately very low. Allotted budget is 2.34% of the total GDP, and the doctor-patient ratio is also quite low, 5.26 per 10,000 population. Now I am going to highlight on the epidemiology of the disease. জলমিলে মরিতে হবে অমর কে কথা কবে চিরস্থির কবে নির হায়রে জীবন নদে. We know that we have to die, and there are so many killers around us to claim the life of human being. Cardiovascular disease is a leading cause of death worldwide and also in Bangladesh. Coronary artery disease and stroke together forms the lion's share of cardiovascular disease. Cardiovascular disease is prevalent worldwide, including South Asia. As you are seeing here, this is the illustration displaying the prevalence of cardiovascular diseases in South Asian country. And on the right side, you are seeing that the proportion of deaths caused by ischemic heart disease and stroke in the South Asian and nearby countries. And you just look at the situation of the Bangladesh. The peculiar aspect of Bangladesh is that here the prevalence of ischemic heart disease as a cause of death exceeds coronary artery disease itself. What is the prevalence of cardiovascular disease as a whole in Bangladesh? Recently, a beautiful meta-analysis has come out, and according to that meta-analysis that has been done by Muhammad Jiaul Islam Choudhury from the University of Calgary, Canada. And in this meta-analysis, the prevalence of cardiovascular disease in Bangladesh is now has been shown to be 5%. I must say that this is excluding the prevalence of hypertension, and the predominant form of cardiovascular disease is ischemic heart disease, and there was no sex difference. If we look at a very recent cross-sectional study, this has been included around 12,000 respondents in adults. And here the prevalence of cardiovascular disease was 4.5%. And among these, heart disease was 3.2% and stroke was 1.8%. Coronary artery disease prevalence, there are some studies that are to some extent old. And the special aspect of coronary artery disease in Bangladesh is that all the features of South Asian coronary artery disease predisposition are applicable to Bangladesh as well. And the disease here is characterized by premature in onset, more severe, and follows a malignant course. But why? The exact etiology we do not know, but probably the main explanation is the presence of South Asian ethnicity and the genetic makeup which is inherent to the population of this region of the world. There are some prevalent conventional risk factors. we all know that hypertension, dyslipidemia, diabetes mellitus, smoking, obesity, and also lack of physical exercise. Metabolic syndrome is unduly prevalent here. There are some unconventional and emerging risk factors as well. I am talking about air pollution, hypovitaminosis D, infections, especially Helicobacter pylori, psychosocial stress, environmental pollutants, especially arsenic, lead, and cadmium, which had been to some extent displayed in the ongoing BRAVE study, noise pollution, and also low birth weight and childhood malnutrition, though they are less appreciated, but still they can have important role in the etiopathogenesis of coronary artery disease in this subcontinent. Like cardiovascular and coronary artery disease, the risk factors are also quite prevalent here: hypertension, diabetes, obesity, tobacco smoking, and physical activity, according to the latest cross-sectional study carried out here. If we look back to the magnitude of 10-year atherosclerotic cardiovascular disease in Bangladesh, only one large-scale study has been available, and this has been carried out by Muhammad Hanif. In this study, they have used the WHO non-laboratory based cardiovascular disease risk assessment chart. WHO has got two charts. One is based on the just clinical features and aspects only, and the another one is based on some laboratory parameters including cholesterol and like this. According to this risk prediction chart, which included more than 7,000 males and females aged between 40 and 74 years, elevated cardiovascular risk was present in nearly 27.5% of both sexes, and male shared 33.7% and females 20.4%. So we can say that 1 in every Bangladeshi adults has got elevated cardiovascular disease risk. What about our children? We all know that our children are probably not so healthy, and it has been beautifully displayed in a recently published cross-sectional study involving 5 urban and 5 rural schools, involving nearly 900 Bangladeshi children between 12 and 18 years of age. And what was the result? Adiposity, that is the presence of overweight and obesity, was nearly 20%. Lack of physical activity was very high, nearly 80%. And there was insufficient consumption of fruit and vegetables, and nearly 98%. So these features are very, very alarming. We know that hypertension is also very prevalent in Bangladesh, and there are a number of studies that are to some extent old. I am going to highlight only the more recent one. I am going to talk about a meta-analysis which has been published by Dr. Choudhury from the University of Calgary, I mentioned already. And according to this meta-analysis, the pool prevalence of hypertension right now in Bangladesh is 20%. And as you're seeing in the graph, that the prevalence is rising. According to the latest large survey, I am talking about the National Demographic and Health Survey 2017-18. The prevalence of hypertension is 26.2%. Probably these two figures are the latest one describing the prevalence of hypertension in Bangladesh. So if we come to a conclusion, it is that every 1 in 4 Bangladeshi adults are hypertensive. What about the prevalence of hypertension if we compare with the prevalence in Asian countries? Look at this. Bangladesh is securing the middle of this chart. Salt intake has got a big impact on the prevalence of hypertension, and just few data are available regarding the salt intake in this population. In that study, it was found that almost 2/3 of the Bangladeshis took extra salt, and the daily salt intake was almost 3 times the upper allowable limit defined by the WHO and the Food and Agricultural Organization of the UN. Regarding the prevalence of diabetes and pre-diabetes, luckily we have got a meta-analysis available, and in this meta-analysis involving nearly 80,000 individuals, and the pool prevalence is for diabetes, this is around 8%, and for pre-diabetes almost 10%. So we can say that nearly 1 in 5 Bangladeshis suffer from dysglycemia. Prevalence of dyslipidemia suffers from inadequate data. However, one meta-analysis has demonstrated that the prevalence of dyslipidemia might be around 35%. So 1 in 3 Bangladeshis may have dyslipidemia in fact. Smoking is quite prevalent in this region of the world, and according to this graph, you are seeing on the left side that the position of Bangladesh is quite in the upper part among the Asian countries, not only South Asian countries. And we are just only in the lower position in comparison to Myanmar. According to the NCD Risk Factor Survey 2010, the prevalence of tobacco in men was 54.8%, and in another meta-analysis published in 2016, the prevalence of smoking was 40.56%. So almost half of the adult males in Bangladesh are consuming cigarettes. Regarding overweight and obesity, the latest survey has come to a conclusion that the overweight prevalence and obesity in men is 18%, and for women 32%. So our women are even bulkier than male counterparts. Every 1 in 5 men and 1 in 3 women in Bangladesh are either overweight or obese. If we now are going to conglomerate the risk factors, we can come to another point, is that the prevalence of metabolic syndrome is very, very high here. And according to the latest meta-analysis, again published by Mr. Chaudhuri, and here 1 in 3 Bangladeshis have metabolic syndrome, and the prevalence of metabolic syndrome in this population is nearly 30% in general. And look at the graph, the prevalence is rising continuously. By this time, I have shed light on the conventional risk factors, but this is not the end. I think some are left very important. I am talking about an emerging threat, that is the air pollution. Recently, air pollution has been considered the most important environmental risk factor for the cardiovascular disease throughout the world, and this is a global perspective. And you know that the particulate matter pollution with 2.5 micron or less in diameter are the very risky substances, and they are directly linked to the cardiovascular diseases in human being. If you look at this slide, we are unfortunately ranking the first position in the world. Particulate matter air pollution is at least 4 times the WHO recommended standard in all 64 districts of Bangladesh. And the Bangladesh average is nearly 76 microgram per cubic meter, whereas the WHO standard is only 5, and our national standard to some extent not so stringent, and that is set at 15. Air pollution shortens Bangladesh's life expectancy by 6.7 years. Another new emerging threat, noise pollution. Just last month, a report was published from the UN Agency on Environment, and they have just showed that Dhaka, the capital city of Bangladesh, is securing the first position as a city regarding the noise pollution in the world. And according to a recent study, 1 in every 20 heart attack patients in New Jersey, the underlying etiology is noise pollution. So we should think of the link between noise and cardiovascular disease, especially in these subcontinents, and also especially Dhaka. We have some good points, regarding the prevalence of rheumatic fever and rheumatic heart disease, this is declining, but this is not faded out, as is evidenced by the ongoing prevalence of chronic rheumatic heart disease in Bangladesh. Probably the current prevalence is less than 1 per 1,000. Now, another ticking time bomb that is a great concern for us, the presence of heart failure. We have no adequate data, but what I can see right now is that it is increasing. Why? Because of the increasing life expectancy and also better management of the coronary artery disease patients of our population. We do not have any community data regarding congenital heart disease. We have some data regarding the prevalence of stroke in Bangladesh. And according to the data, available data, the prevalence is around 1%. So, in a nutshell, the prevalence of cardiovascular diseases in Bangladesh for hypertension, this may be 20 to 25%, coronary artery disease 4 to 6%, rheumatic fever and rheumatic heart disease may be less than 0.1%, congenital heart disease and stroke I have already mentioned, and unfortunately right now for heart failure, arrhythmia, cardiomyopathies and peripheral artery disease, no community data are now available for presentation. With this, I like to go to the next component of my presentation regarding the challenges is primary prevention of cardiovascular disease in Bangladesh. Mind it, this is not for secondary prevention, this is for primary prevention. According to the ESC guideline for preventive heart prevention available just last year, they have suggested that the primary prevention should be at 2 levels. One is at individual level and another one is population level. We have a lot of challenges at individual level. Unhealthy diet is a big problem for us. Our diet is predominantly composed of high carb diet. High trans fat is a reality for us. Saturated fat is probably another problem. Junk food and sugary beverages are especially a great concern for the young population and children and young adults of Bangladesh. High salt intake, as I have already mentioned, is a big concern. Reuse of cooking oil, this is another important aspect. And to save the total quantity of oil consumption in a family, just people in our Bangladesh often try to reuse the cooking oil. And this is a very bad practice because during the reuse of cooking oil and deep frying, cis fat is converted to trans fat. And that is a documented cardiovascular risk factor in the country. Lack of physical activity is a great concern, lack of knowledge, lack of motivation, and also poverty. Psychosocial stress is often less appreciated, but it is also another important aspect of challenge at individual level. And now, challenges at population level. Insufficient epidemiological data is a great concern. Another one is that we have some studies by this point, but unfortunately, we do not know any cohort studies. Cohort studies are very important for just getting insights into the inherent problems of a population regarding the cardiovascular disease. We have no calibrated cardiovascular disease risk prediction chart. This is another one important drawback for us. We have suboptimal health education, underuse of mass campaign. Ongoing poverty is a big problem. Inadequate health expenditure. Just look at the situation right now. Per capita expenditure in Bangladesh is right now $46. And on the other hand, in the USA, this is around $12,000. Control of tobacco is a great concern. Tobacco companies are among the highest taxpayers, so we cannot neglect them. High level of air pollution, food safety including trans fat content, we should think of this. Too much emphasis on treatment and secondary prevention of cardiovascular disease, and inadequate preventive and promotive health, cardiac health care is another drawback now. So, at the conclusion, I like to say that let the World Heart Day 2022 be a turning point for us. We have experienced spectacular epidemiological transition from communicable to non-communicable disease. We have measurable economic and nutritional transition, but now we have to welcome transition in our thoughts. We have to boost up preventive and promotive cardiology to have a healthy nation. With this, I like to thank you all for patient hearing. Thank you all.
Thank you, sir. We'll have the question and answer session and discussion at the end of the session. Now, our next distinguished speaker is Professor Dr. Joseph M.C. Rosano, who is getting connected with us. So before we start his presentation, we would like to have a brief biography of him. So Dr. Joseph Rosario is Professor of Cardiology at St. George University Medical College in London and President-elect Heart Failure Association. He is also the co-director MSc Heart Failure, and he started his educational career obtaining his MD in Medicine and Surgery at La Sapienza University of Rome with full honors in the year 1988. Dr. Rosario obtained his specialization in cardiology in the year 1992 before attaining his MSc and PhD in medical sciences from the Imperial College in London. He has extensive experience in cardiovascular pharmacology, heart failure, ergometry, echocardiography, and vascular ultrasound. He has authored over 500 peer-reviewed articles, 5 books, and 28 book chapters. He is currently Consultant Cardiology Professor of Cardiology at St. George's University Medical College in London, and also the Professor of Pharmacology at St. Raphael University in Rome. He has served as an expert in the area of cardiovascular medicine for the European Assessment Office of the Italian Drug Agency. He has been a core member of the Cardiovascular Working Party of the European Medicine Agency. His research interest includes clinical pharmacology, gender differences in cardiovascular disease, heart failure, ischemic heart disease, microvascular angina, and the cardiovascular effect of non-cardiovascular drugs. He is a board member of Heart Failure Association, chairman of the Educational Committee, and president-elect of Heart Failure Association. We'd also like to thank Servier for arranging and coordinating the whole process of him participating in our today's conference. We are greatly delighted to have his speech to enlighten all of us. His today's topic of presentation is on atherosclerotic cardiovascular risk assessment and stratification for prevention of cardiovascular events. We'd like to invite Dr. Joseph Rosario for his speech.
I hope you can hear me because your audio is really bad. What I will do in the next 15 to 20 minutes is to discuss with you the atherosclerotic cardiovascular risk assessment and for the stratification and prevention of cardiovascular disease. Now, we've heard the data earlier from Bangladesh, and these are worrying. And we know that cardiovascular disease is the leading cause of death. That is not just in developed countries, but also in developing countries. And if we look at the overall, cardiovascular disease is by far more frequent in terms of death than cancer or other more common diseases. Usually, and it is important to highlight today that there are nearly 17.5 million deaths per year globally, And cardiovascular disease accounts for more than 4 million deaths each year, just across Europe. So you can see that that is a very important issue. Now, the cardiovascular mortality is in all the different countries, and you can see the stratification here according to the different geographical regions. The mortality is mainly driven by ischemic heart disease and stroke. And you can see how in Southeast Asia that is still holds through, but also what is important is also the presence of hemorrhagic stroke. Now, going into discussing how to assess and determine cardiovascular risk, now we need to say that cardiovascular disease is not something that is new. These are studies of the Egyptian mummies of more than 3,000 years ago. And as you can see, it was possible with CT scanning to identify already at that time the presence of plaques here on the abdominal aorta and on the aortic bifurcation and iliac artery. You can see here the disease on the carotid arteries, calcifications of the aorta. So the atherosclerosis is nothing new and is present in all the different continents. Now we know that the coronary artery disease, atherosclerotic artery disease can present as a disease of the aorta, as coronary artery disease, but also with peripheral vascular disease. And the peripheral vascular disease can occur in different territories, like carotid vascular disease, vertebral, cerebrovascular, then upper extremity artery disease that is not very frequent. The mesenteric artery disease that is often misdiagnosed, and renal artery disease and lower extremity artery disease, and they can present in all the different forms that go from a stroke to a Steele phenomenon to hypertension and abdominal claudication or claudication. But what has happened is that very often we have patients that tend to have multi-site arterial disease. What is important, however, is not the presence of a plaque and the degree of stenosis, but how that plaque is active and tends to rupture. You see that these are studies performed looking at the presence of thin cap, and those patients having a thin cap, even with very small obstruction of their coronary arteries, had a significantly higher event rates than those patients with very severe stenosis, but with a fibrous cap. So it's not just importance of the plaque, but it's also important the structure. And of course, the different localization of atherosclerosis may have differences that are related to the different forms of the vessels, because there are some vessels that tend to be more elastic, some more fibrous, and therefore the response is different. And this is the difference, for example, in an elastic artery, like the coronary arteries, or, as you can see here, the peripheral vascular arteries. So the internal carotid arteries and the superficial femoral arteries are more muscular arteries and have a similar pattern. You can see also that there are differences in how the atherosclerosis expresses in the carotid artery and in the coronary and in the femoral, where you see that the lipid core is more internal and then tends to develop later in the carotid artery. So we have a continuum of patients at risk for cardiovascular events, and this continuum of patients starts from those patients at low risk, then we go into patients with multiple risk factors, with subclinical atherosclerosis, and to get to patients with post-myocardial infarction and angina. Now, whilst it's easy to identify those patients with evidence of atherosclerotic manifestations, it's important to identify those patients who are at increased risk. And we've heard from the previous speaker the importance of obesity and other risk factors that tend to cluster often in patients and increase their cardiovascular risk. And we know that the increased cardiovascular risk is given by the combination of all the different risk factors, but also is partly genetic, is related to the age, sex, and race, is also depends on the family history. But then we have modifiable risk factors, amongst which we have dyslipidemia and hypertension, who are the most important, but also type 2 diabetes. What is important is that in patients with type 2 diabetes, it's much more important to reduce lipids and blood pressure rather than reduce glycemia. Now, we know that lipids are important, and these are data from the study conducted specifically in patients with diabetes. And you can see that in diabetic patients, the most important variable are lipids, then is the glycated hemoglobin at the same level of blood pressure. Now, we know that it is important to reduce the lipid, the LDL cholesterol and the dyslipidemia, as reducing lipids reduces cardiovascular and vascular events. And of course, the reduction has to be in line with what is the appropriate target, and the target differs in patients with high risk or in patients with low risk. But even when we reduce the cardiovascular risk with statin, we still see a very important and significant residual risk. Now, we know that we have recommendations on how to estimate the risk. Now, we need to use a total estimation risk using the score. The score is recommended for all patients above 40 years of age without any evidence of disease, because if they have diseases like diabetes mellitus and CKD, they are immediately at high risk. And for this, we have a level of evidence 1. So it's important to assess the cardiovascular risk. Then it's important that in patients high risk, with due to the presence of cardiovascular disease, diabetes mellitus, or moderate CKD, it is important to look at the individual risk factors. Now, how we do that? We do by using the estimation charts. And the estimation charts, they estimate the 10 years risk of developing cardiovascular disease, and this is based on gender, smoking status, age, that are plotted against blood pressure and total cholesterol. Then, once we have estimated the risk with grossly, then we need to refine it, and we refine it by adding the HDL cholesterol. So, first of all, it's important to identify which are the risk categories. We go from the very high, that is very high risk, and this is easy because of patients with documented cardiovascular disease and the presence of coronary artery disease, atherosclerotic disease, a previous MI, previous CABG, but also those patients with diabetes mellitus with target organ damage. So if we have a patient with diabetes mellitus who has also, say, carotid atherosclerosis, peripheral retinal issues, or as a CKD, that is a patient that is at very high risk. Then we have the high risk categories. Now, those patients with dyslipidemia, those patients with diabetes mellitus without target organ damage. You can see that already being diabetic or having an abnormal glucose profile like the obese patients place them at high risk. And then, of course, we have the younger patients that are moderate risk if they have diabetes or elevated lipids. So this is a way of measuring the risk. These are data from Europe, but there is a conversion of this table for all parts of the world. And therefore, once you get a number, then you know from the conversion table how that equates in the different area of the world. Now, we can first of all divide in charts for men and women. And you can see that, of course, the risk is higher in men. You can see that for the same age, the same profile, you see the cardiovascular risk is always higher in men than women. Then when you go more specifically, so you have let's say you have a male patient who is a non-smoker, then you use the non-smoker category. Then you look at the age, so let's say is a 60-year-old or 65-year-old, then you choose the right panel, and then you plot the blood pressure, let's say in this case 140, and the total cholesterol, in this case 5. So this patient has a risk of, initial risk of 4. But then we can further refine that risk, and by using not just the blood pressure and total cholesterol, but looking at the HDL cholesterol. And you can see here how in the same patient, the cholesterol, the risk may vary substantially whether that patient has a low HDL or high HDL. You can see that if that patient has a high HDL, his risk is 3, so it's lower. But if it has a low HDL cholesterol, then the risk is nearly 3 times higher. So we need to redefine the risk using the HDL cholesterol. So this is shown even better here, so by focusing on that specific patient, but also if we take another patient with a risk of 6, we see that in those patients with, if he has a very high HDL cholesterol, the risk becomes 4, so it goes from a high risk to a moderate risk. Whilst if it's if that patient has a let's say low HDL cholesterol, then the risk becomes 10, which is very high. So it's important to calculate the risk, and it is important always to look at the charts, because several studies have demonstrated that even if we know very well the charts, then we always tend to either overestimate or underestimate the risk in all patients. Then, once you've done that, we can also use a vascular ultrasound in order to look at the plaque burden. But then, if we identify, let's say we have identified a patient with moderate risk, then we use a vascular ultrasound and we find a plaque that per se identifies a patient with a very high risk of disease. So we can use the vascular ultrasound to further refine the assessment of risk. Then once we have the overall picture, that we need to understand how to treat that patient. And we treat that patient according to the cholesterol levels or blood pressure levels, and so similar charts are present for cholesterol and for diabetes, and then according to the class level. And you can see that we have patients where we can just give lifestyle advice, or those patients with lifestyle advice and need of immediate intervention. Aiding the risk also is important to determine the target for our patients. Because if we have patients with a very low risk, then the target for our LDL cholesterol is 3 millimoles per liter, or 116 milligrams per deciliter. If you have a patient with a moderate risk, then the target becomes lower, 2.6. If you have a patient at high risk, should be 1.8. In those patients with very high risk, then you see that the target cholesterol must be even lower, so 1.4 millimoles per liter or 55 milligrams per deciliter. Now, going towards the end, how we put all of them together. We look at, when we get a patient, we need to assess the cardiovascular risk. Then we use the score charts to initially identify the risk. Then we have the baseline, we measure the baseline LDL cholesterol. Then we look for modifiers like, say, subclinical atherosclerosis, and we have a clear idea of what the targets for our treatments are. Then we see whether there is an indication for drug therapy based on the risk level. And if there is an indication, then we need to define the treatment goal according to the degree of risk. So we can start, for example, in this case, the use of a statin if we are targeting cholesterol. But of course, if we have to target blood pressure, our blood pressure targets according to age and race. And whilst in patients who do not need treatment, we need to have lifestyle advice and, if needed, intervention. Then if the LDL goal is reached, we continue that patient on therapy. If it's not reached, we increase. So you can see that it is important to assess risk, because by assessing risk, we can identify those patients who will need a more aggressive treatment, and also we can target the treatment according to the target levels for that specific condition. And I will stop here. I'll be happy to take your questions if I'll be able to hear.
Thank you, Rosano. Welcome you, Bangladesh, from IPDI Foundation. Can you hear us?
Yes, I can.
Thank you. I'm requesting Professor Abdul Wadud sir, please, our chairman of IPDI Foundation, please welcome Dr. Rosano.
Hello. I hope, Professor Rosano, can you hear me?
I can hear, but I cannot hear you. Yes.
We are really glad that you have joined with us. And you know, we have had a conference on preventive cardiology long ago. And this is the second time we're actually paying attention to. And we hope with this conference, our young cardiologists and physicians across the board, they'll be more concerned about the preventive aspect of a disease that is actually a killer. And your lecture will be giving attention to that. My one question is, do you think the score system that has been developed for the European population is applicable to the South Asian population? We have the genetic difference and other things and different type of lipid profile. Whether this score system is will be good for us, or do we need to develop another one?
Let's say the score system is the system is applicable worldwide, probably except in America. And we have the conversion table. In the ESC guidelines, you'll find that there is a conversion for the different areas of the world. So there is a specific conversion for Southeast Asia. So you know that when you get, say, 4 in the score chart, most probably it is 5.6 in Southeast Asia. And so you can select your area and region of the world and convert the ESC score into your region. And that is very accurate, because is based on studies that have assessed the prevalence of disease in worldwide.
Thank you, Professor Rosano.
Our senior teacher, our first generation teacher, Professor KHM Shirachulok sir here. Sir, please, any question or any comments? Dr. Rosano, also Dr. Monwarul lecture also. Yeah.
I must congratulate Dr. A.K.M. Monwarul Islam for his brilliant deliberation regarding the epidemiological aspect of heart diseases in Bangladesh. So I must thank you very much.
Dr. Rosano, here Dr. Sandip Mishra here. He is the Vice Chancellor of NINS University, India. Dr. Sundip Misro, please, any question for Rosano?
Yeah, I think regarding the score system, you know, I think you said Southeast Asia. Here we are South Asia. It's a bit different than Southeast Asia because the lipid profile here is much different. So what we do have in this South Asian population is not only raised LDL, which is not that much, but problem is low HDL. Very low HDL. Typically, you know, less than 40, 35, etc. is also very common. And high triglycerides. So, you know, so the conventional risk factors, particularly extreme focus on LDL. Sorry, there is a feeling that, you know, this might not exactly be applicable to South Asian population. And the prevalence of diabetics is also very high here. So, nearly, you know, among the CAD population, nearly 40% are diabetics. So with this, I think the, you know, there is a discussion going on whether those European guidelines or American guidelines can directly be translated, even by a factor, because, you know, it is not simply a question of, you know, more risk factors, but it's a question of different kind of risk factors. So I think it is something, the debate is ongoing still, I feel.
Thank you.
I don't think so. I don't think so because it's as you can see, and as I showed you, our guidelines and the score system also adapts and readjusts the level of risk according to the different levels of HDL. So you get a value that is adjusted to the LDL, so the different lipid profiles. But also, I mean, I was just taking an example for the Southeast Asia. You can go and look specifically in all the different populations, and there are conversions for the different populations in the score system, and you know where your risk is. There's very good correlation that has been shown in populations like Pakistan and India. I'm not aware of specific studies in Bangladesh, but I guess that the difference in terms of risk profile, it's with some Indian population, it's is not very significant. And I think it's the best system we have available worldwide, because unlike the American, that is based on American subgroups, this is based on epidemiological studies that have been conducted worldwide, and therefore the estimation of risk is very accurate.
So I think, you know, one of the issues I think still not addressed is that whatever the major studies are taken to prepare these scores have very few South Asian population. I may say less than 1%. So, you know, while, you know, because of absence of anything better, while this might be working to an extent, but I still feel that we really require, you know, and as you know, the world population, you know, is skewed. It's mostly South Asian now and others from this area versus the West, which is now a minority in times to come. So, you know, while the studies, 90% are on a Western kind of population. So I think it is still, you know, while, you know, you're right that in absence of anything better, you can still have to rely on this. But I think we need more data on, you know, South Asian population.
Thank you.
Absolutely. I mean, it was not just 1%. I mean, what it was extensive in terms of population. I mean, you can start doing a study now. It will take you probably another 20 years to develop a score, because if, of course, you need to have a long period of observation to have that. So in the absence and whilst waiting for that to happen, you need to use a system, and this is the best system that is available worldwide. At the same time, of course, it's important to develop the score, a proper score, or to validate whether there are differences between the different populations still exist. But I think that the one I showed you is the global score that is validated everywhere.
Thank you, sir. In front of us, more than 200 faculties and delegates in front of us. Any question from the delegates or faculties here? Any question? I think Major General Guran Abbani, sir. Major General Guran Abbani.
Professor Rosano, thank you very much for your brilliant presentation regarding atherosclerosis. Out of inquisitiveness, I have got a question to you. In South Asia, the cardiologist gives severe restriction of food intake regarding your fat, animal fat, butter, cheese, or other fat-containing foods. But if we look towards the animal kingdom, we see that cattle, the goats, they do not eat any fat. They only live on grass, but their body is full of fats. So is it logical to give severe restriction to fat intake for prevention of atherosclerotic heart disease? Rather, I would say that endothelium, the lining, these cells are actually sandwich type. Inner side and outer side is made of protein, and inside it is fat. So some fat is needed for your resistance for this endothelium. They tear because of the high rise blood pressure. If do not take fat, I think endothelium remains weak and they get tear. So that is my out of this question. A lot of places I ask this question and no answer is there. Thank you.
Yeah, I think it's, thank you for your question. I think we have very good data on populations and over the past 2,000 years, and we have we know what the levels of cholesterols were, say, 2,000 years ago, 1,000 years ago, when cardiovascular disease was not very prevalent. So there is an indication for reducing the LDL cholesterol. Then your question was very pertinent on the diet restrictions. And diet restrictions can be different in different subjects, because we have if we have a young subject that has a very active and social life, then it will be more difficult to restrict diet compared to someone who's less exposed to different type of food. So it is important when we get to a moderate degree of risk to reduce lipids and to reduce it with a statin, and then adjust according to diet without being too restrictive, because we can restrict diet and diet can work a little bit. I mean, it's not great in terms of reducing cholesterol, but at the end, especially young patients, they can keep it on for 1 year, 2 years, but then they will go back to normal. And whilst we lose the possibility of our interaction and starting on preventative strategies.
Dr. Govindo Kantipal.
Thank you, sir. Professor Rosano. I am Dr. Govindo Pal, Mymensingh Medical College, just 2.5 hours away from Dhaka. I like to ask about the score system. Why only systolic blood pressure considered here? Why not diastolic blood pressure? And also regarding lipid, only consider total cholesterol. Why not HDL, LDL, lipoprotein, and why not age variation? This score system, I'd like to know. Thank you, sir. Thank you, everybody.
Look, do you know that we use in different countries the non-HDL cholesterol? Therefore, using the total cholesterol and adjusting for the HDL will give you immediately the non-HDL and therefore the importance of the LDL cholesterol. So that is the best way of assessing it. Regarding blood pressure, if you have elevated systolic blood pressure, or for any given value of systolic blood pressure, then the diastolic blood pressure changes a little bit the overall risk. But of course, if you identify that someone is hypertensive, you don't need to have the score chart, because that patient is already at high risk, and therefore your strategy is to reduce the blood pressure, bring it to risk. So it's not the issue of taking a blood pressure below 90, but if a patient has already diagnosed hypertension, by definition is already at high risk.
Thank you. Professor Syed Nasiruddin, please comment.
Thank you, Dr. Professor Rosano, for your nice presentation. I like to ask a question to you. Since you have got a score, sort of these predictions in Europe, but we have got no such score system in Bangladesh. But as you know, there are a lot of populations, South Asian populations in UK, and you have just estimated the risk in different studies. So can you project any risk like a stratification chart, like a score for the Bangladeshi or South Asian peoples?
As I said earlier, we have validation. I mean, this is a very important question because we have a validation of the score system that has been made in say the first comer generation into different European countries. And this is important. The reason why I'm saying the first comer generation is because if you take second generations, then you already have the diluted effect. You keep the genetics, but you lose the effect of the specific diets, because then they tend to be adjusted to the diet. And we know that from, for example, the old Honolulu study where, the Japanese moving to Hawaii, they kept the risk profile for the first generation, but then the second generation had the risk profile that was more similar to the Americans. So when we look at those populations, we see that the score risk with the correction by country is still holds true, and you can have a good prediction of the overall risk using the score and adjusting for the different populations. And you're right, we have a very high prevalent population of say Indian, Bangladeshi and Pakistani in the UK, and we often use the correction tables together with the score whenever we see a patient coming, especially coming from as a first generation.
Dr. Dipal K. Adhikari.
Thank you, Professor Rosano, for your excellent presentation. I think the most discussed subject, the scoring system, is developed in the western part of the world. And the population taken here is from the NRBs or NRIs, who is immigrated to the western worlds. And they are, I think, 4 to 5 times the greater risk of having CADs in comparison to the local people. And this is the most striking risk factor among them. But as such, the residing in Southeast Asian or South Asians is also a risk for us. I think we have to work with our own data. Till now, as we have no own data, we have to work with those data and have some conversions. And we think we can work with the data and work with them hand to hand. Thank you.
Thank you, Professor Rosano. We are eagerly waiting to welcome you as physically next year. Dr. Rosano?
We'll be with great pleasure.
Okay, thank you, sir. Also, thanks, Dr. Monwarul. Thank you so much for the excellent lecture.
So now I'd like to invite Dr. Monwarul Islam to receive his crest from KM Shirazul Haq sir. So we'd conclude the first session. Now I'd like to invite Dr. Aifur Rahman to moderate the inaugural session.